Well, hello everyone. This is Gap Madrigal Mesh Community Network, sponsored by Madrigal. I do see some familiar name and then some not, but it's all good. I'm very happy everyone's joining today. I know your time is very valuable. Thank you so much again for joining me today. My name is Valerie Shin. I'm a nurse practitioner. I work in hepatology at UCLA Health, Los Angeles, California. This is part of Gap Madrigal Mesh Community Network series. Today we'll discuss case number 6, how to compare F3 and F4 fibrosis in patients with MASH. This case is actually pretty fun. It's not like lecture. We can make it a little more interactive if you wish. And if you do not want to talk, that's fine. I'll do more talking. That's no problem. So you are already registered for this class. Thank you very much. But if you haven't registered, this is the attendance QR code. So please use this QR code. So sign in your name. And once also registered, you will have access to schedule to other Madrigal Mesh Community Network series. We have a lot of series that you can enjoy about fatty liver. We're going to start right in with the case. This is Smith, 55-year-old Caucasian male with body mass index 33. So he went to see a primary care provider and then had a routine lab and then found liver tests were slightly elevated. Therefore, abdominal ultrasound was completed and it did show increased liver echogenicity, which means probably steatosis. And he also reports his fatigue.
Oh, you had the
Smith,
audio off.
I'm sorry? Hello? Can everyone hear me? It's good? Okay, I'm going to continue. Smith has past medical history of diabetes, high blood pressure, dyslipidemia, sleep apnea, and then good news is not drinking alcohol, and I hope that's true. Physical exam, he does have obese abdomen, no stigmata of advanced liver disease, meaning there's no fluid shifting, dullness, no collateral spiral angiomatas, no muscle wasting, and then no appreciated hepatosplenomegaly, which is good. His medications includes lisinopril for high blood pressure, rosuvastatin, ezetimibe for high cholesterol, and then he's taking Farxiga for his diabetes. Labs. His vital sign, blood pressure is 140 over 78. Is slightly elevated. I don't know if he took his morning meds. I don't know yet. It could be just that he has a white coat syndrome, or maybe blood pressure is not just controlled. His weight is over 200 pounds, definitely under obese category. BMI is 33. We did mention that. His blood work, ALT, AST is not crazy high, but it is slightly elevated. ALT 85, AST 72. Alk Phos and total bilirubin is slightly elevated as well, 120 and 1.17. Platelet is 157K. It is not complete thrombocytopenia, but is right at borderline, but I would still call that low normal. A1C is 7.1%, but remember he's taking Farxiga, so I'm not sure if I'm too happy with this A1C. I think he can do a little bit better. Other labs, his kidney function and INR looks great. His ferritin's a little bit elevated, but when I look at his iron saturation percentage is 30%, I don't think he has iron overload. ANA, the autoimmune marker, is mildly positive 1 to 80. SMA was negative. Hep B, Hep C screening were all negative. So fibrosis assessment. So if you recall, patient had confirmed steatosis on imaging, right? So next step is to assess the degree of fibrosis in the liver. Simple ultrasound abdomen is not good at telling us how much scars in the liver and if there's any inflammation or not. So the easiest and simplest non-invasive test, we call it NIT, to stage the liver is FIB-4 score. It's a clinical calculator. It uses patient's age, platelet, ASC, and ALT level. FIB-4 score less than 1.3, the patient is considered low risk. FIB-4 score over 2.67 is considered high risk for development of fibrosis. And in between is medium risk. Please note that for a patient who's over 65, the reference range can be different. So if FIB-4 score is under 2.0, that is still considered low risk for patient over age 65. Smith has before score of 2.6. It falls under intermediate risk, but if you look at it, it's like right below the high risk. So you got to consider that. But technically, he's in between risk. Patient also has some other NITs called FibroScan. FibroScan, we love it. It's a brand name for a type of elastography. It's quick and easy. It can give me like result immediately after the test is done. That's only if you have the machine in the clinic. It provides a liver stiffness measurement. When the result is over 12.5, it suggests cirrhosis. So Smith has right below that range 11, which put him most likely F3 fibrosis. The fibrosis, very interestingly, give us the second result, which is the fat amount called CAP score. Smith has CAP score 262. FibroScan has different parameter for different diagnosis. For steatosis, 262 falls under moderate steatosis. But again, if you look at close, it's very close to severe steatosis range, 262. He had another NIT. He had a lot of NITs, which is great. More data is great. It's called ELF test. It's a blood test. It uses different serum biomarkers to suggest fibrosis. Just a quick side note, the serum biomarkers are used for this test can detect non-liver fibrosis as well. Please do not use it if patient has like pulmonary fibrosis, for example. Otherwise, it's a good test. Smith has 9.9, which suggests severe amount of scarring. Over 11.3 is suggestive cirrhosis. So after seeing this, would you like to order any other testing for this test? Audience, anyone? If you have microphone on, if not, no problem. It's fine. For serology, I would love to order some extra tests. So if you recall, his ANA, the autoimmune marker was positive, mildly positive, and he does have a transaminitis, right? So I'll definitely complete autoimmune hepatitis workup, which is serum IgG. I'll check the protein gap as well, so I can completely just rule out autoimmune hepatitis. I'll probably order some celiac tests as well, just to complete the abnormal liver test workup. When patients younger than 50, I tend to order ceruloplasmin as well. That's going to rule out the Wilson disease. Smith is 55, so I would not order ceruloplasmin. For alternative NITs, we could consider MR elastography. FibroScan is a good test. I told you I love it, but it does provide limited result if patient has a lot of fat around the belly and when their BMI is over 30. So for him, his BMI was 35. So MR elastography is something I would consider, but then it's not widely available. It's just some centers have it. And also MR elastography, if someone has claustrophobia or have back pain, you can't lie flat for too long, has non-MRI compatible metal implants, then you should not consider. Although not common, liver biopsy can be considered. Mr. Smith, though, he had a good amount of consistent data that tells us the same direction, so no biopsy is actually needed. So with the provided data, what stage do you think this patient has? Anyone brave enough? I can't see the conversation box. So if you want to say it, you have to put the microphone on and say it. So what stage is this patient? Yeah, I think patient has MASH with F3 fibrosis. Okay, so we agree that Smith had F3 fibrosis. How would you treat this patient? And how would you monitor this patient? So we'll talk about that. For any MASLD and MASH patients, behavior change is the key. This patient must adopt healthy lifestyle habits, including Mediterranean diet, continue to avoid alcohol because it's like putting fuels on fire. They gotta exercise regularly, although I believe diet is more important than just the exercise. Weight loss is the key. I strongly recommend this type of patient aim to lose 10% of their current body weight. And with the change, liver disease may regress to an earlier stage. So F3 to F2, F2 to F2, F1. It's important to discuss the sustainable approaches to weight loss, not quick fixes. This type of patients also needs to work closely with primary care provider to tight control metabolic risk factor. And if you recall, Smith had a little elevated blood pressure, even if he's on the medication. And A1C 7.1 may be great, but I'm a little greedy, so I want it less than 7. So that also has to be tight controlled. And also lipid panel. His statin, right? I don't have his lipid panel information, but that has to be tight controlled. And also treating sleep apnea is important too for cardiovascular benefit. How about considering him to see an endocrinologist? Because his A1C is not at goal technically with me. How about clinical nutrition? He's a great candidate for GLP-1, don't you think? Yeah, because he has metabolic syndrome. It can help him to lose weight, and hopefully that leads to better control of his blood sugar, blood pressure, and lipid panel. And there is a first and only one FDA-approved medication for MASH. It's called resmetirom. I may consider resmetirom only if patient for sure does not have liver cirrhosis. Resmetirom is one a day. It's a daily dose, and it's indicated for F2 to F3 fibrosis only. Since Smith has F3 fibrosis, based on 3 different NITs, I would definitely consider him using resmetirom. But taking this medication always come with the, sorry. But taking this medication always has to come with healthy lifestyle changes. Also for advanced liver fibrosis, even if F3, I already start the liver cancer surveillance with AFP and ultrasound every 6 months. So now imagine the same exact patient scenario. Same age, same medical history, same physical exam, and same medications. The vital signs are the same. In his lab, AST, ALT, alkaline phosphatase is the same, but total bilirubin this time is slightly more elevated than previous one. Platelet, now there's an evidence of thrombocytopenia. And his kidney function, for some reason, the number is a little elevated, and other test results are the same. So it's the same patient, slightly different lab result. What if the NIT scores were different too? So let's go over that. So FIB-4 score now is 3.1. It's higher than 2.67, which is like a cutoff of the between medium and high. His FibroScan now shows stiffness of 21. It's way higher than previous slide. The cutoff used for F4 fibrosis is 12.5, and patient have 21. That's very high. For me, it's kind of slam dunk cirrhosis, only if the FibroScan quality was for sure accurate. Okay, and then FibroScan again show the fat amount as well. It's 245, and it's kind of interesting. The stiffness is very high, but fat amount, if you look at the reference range, it's no to mild actually. So does the patient not have steatosis? No, I think he does. Most likely, patient has burnout fatty liver. We see this kind of result when a patient has a significant fat accumulation, but over time, the visible fat is no longer detectable, basically burnt fat. So that progress to advanced fibrosis and cirrhosis, and I think that's what's happening. And another ELF score right now is 11.4. The cutoff for cirrhosis is 11.3. So every NIT is point towards he has pretty severe scarring of the liver. Is there any further testing you'd like to do? Yeah, we previously discussed some other additional tests we would like to do to rule out other causes of elevated liver enzymes and chronic liver disease. And in addition to these, because patient has thrombocytopenia, I would like to see his albumin level. And also, we don't have full report of the ultrasound. Was this a complete abdominal ultrasound? I like complete versus just right upper quadrant because I want to see the size of the spleen. They can kind of tell us whether he has evidence of portal hypertension or not. And also, if patient has, start to have cirrhosis, maybe there's a little bit of ascites that I would like to see it on the complete ultrasound. I would ask the patient if he ever had an upper endoscopy for any reason. to see again any evidence of portal hypertension. Is there any stigmata of esophageal varices? As more pieces of puzzles come together, we can arrive at a more accurate diagnosis. I still don't think liver biopsy is necessary because we have a multiple consistent data to make a diagnosis. So would you say patient has liver cirrhosis? Yep, I think he has a liver cirrhosis from long-standing steatosis. Oh, cool. There you go. So with MASH liver cirrhosis, how would you treat this patient? How would you monitor this patient? Okay, for the management, the lifestyle changes are still the key. Gotta eat clean and healthy, stay active, exercise routinely, still need a good controlled metabolic risk factor, and gotta lose weight. But you have to speak nicely to the patient. You can't just force them to lose weight. They'll not listen to you. They'll never come back to your clinic. So don't emphasize too much on pounds, guide them to have a small changes at a time and use motivational interviewing technique. Due to advanced liver fibrosis, every 6-month liver cancer screening is important and use AFP and ultrasound abdomen. And ultrasound, again, if patient has high BMI, it may not be too accurate. So sometimes I alternate between ultrasound and CT scan. And briefly mentioned on previous slide about upper endoscopy to evaluate esophageal varices because it has a thrombocytopenia. And then we could also consider patient to start like non-selective beta blocker, like carvedilol, correct, for prophylactic for varicose bleed. When I put patient on non-selective beta blocker, am I still gonna do an upper endoscopy? If there's none existing, like I would totally order one for a good baseline and see how often patient needs it. If, oh, sorry about that. Okay, if MEL score is 15 or higher, and patients start to decompensate, such as patients start to have jaundice, ascites, legs edema, hepatic encephalopathy, GI bleed, or bad sarcopenia, I would not delay OLT eval. I did Mr. Smith MEL score. It's 10 right now, and he does not really have a liver-related symptoms much at this time. Looks too soon for OLT eval, but I'll monitor closely for changes. Is he a good resmetirom candidate? I just want to remind you, resmetirom is such a good medication, but it's for F2 to 3 fibrosis only. For this patient with apparent evidence of liver cirrhosis, I will not use resmetirom. For this time, it is not indicated or labeled that way. It's not on here, but for MASH F3 to 4 fibrosis and patients completely compensated, there's no portal hypertension evidence, there's no varices and platelets over 100. I sometimes refer patient for bariatric surgery as well. And I've seen a few successful stories. Patients' liver test normalized right after the bariatric surgery, right? Like immediately after. And people tend to do really great without decompensation. So something to consider. Some other sources management will be if patients start to develop fluid retention. You want to evaluate whether we need to start diuretics. Of course, emphasize on low sodium diet. And then if patient has a lot of ascites, we'll order diagnostic paracentesis to see SEG. If albumin levels are low and you see the sarcopenia, you do want to encourage patient to consume more protein shakes or protein intake and absolutely no alcohol or any kinds of forms. Limit the Tylenol use for 2 grams a day max and avoid raw shellfish and oysters. Is there anything else I'm missing that you can say it so everybody can hear? Nope. Okay. These are just comparison of the NITs that we mentioned, the first case versus the second case of the Smith. The point is the ELF score is much higher on the second case, but fat amount was really lower. It's because the burnout fat doesn't mean patient does not have MASH. And I like to emphasize that the core objective of this case comparison is to illustrate the critical importance of accurate fibrosis staging in liver disease. The accurate staging is crucial for prognosis and risk stratification and management decision. Yep. Okay. So the question we should still need to discuss is how do these two cases compare in management? I think we talked about that. And staging between F3 to 4, which NIT do you most typically use to differentiate between the two? Well, I tend to use FibroScan, as I told you, because it's such an easy tool and I can have the result immediately. But on the other hand, if FibroScan machine is hard to find, or you live in suburban area, there are not much of FibroScan machines available, then it could be limited. Then you can totally use the ELF blood test because it's easy. A little downside of ELF score, ELF blood test is that once you submit it, it takes a while to get it back. It can take a few days. So if you want to make like immediate like management plan, you have to wait. And FIB-4 score is easy to use. We tell primary providers to use it and community GI doctors to use it or providers to use it. Those are a good alternative. Okay. And then what about indeterminate NITs? So ELF score, FIB-4 score, you have FibroScan, MR elastography, you have everything, and then you still have um, if the result is like everywhere, it's not telling you just one story, then that's the time I would consider liver biopsy. And of course, F3 to F4, to me, those both advanced liver scarring. So I would totally do every 6-month liver cancer surveillance with ultrasound and AFP. And again, with elevated BMI, I would alternate between ultrasound and CT or MRI every 6 months for accurate surveillance. We're done. This last QR code is for the resmetirom, all right, Resdifra webcam. I checked it out. It's a very good video. So if you like to check out more information about disease state, more education material, it's right here. So you can go ahead and take a picture to save it for review in the future.